So we are live in 3, 2, 1. So welcome to OrthoTV, and I'll hand it over to Dr. Ravi for further proceedings. Over to you, Ravi.
Atul sir, please.
Good evening, friends. On behalf of Delhi Orthopaedic Association, I welcome you all for this 4th episode of our DOA trauma series on pediatric fractures. The topic chosen for the day are very relevant for our day-to-day practice, and we are honored to have with us today President, Paediatric Orthopaedic Society of India, Dr. Dhiren Ganjwala from Ahmedabad, Secretary, Paediatric Orthopaedic Association of India, Dr. Sandeep Padvardhan from Pune, Dr. Vikas Gupta from Delhi, our own colleague and a very close friend of mine, and Dr. Pratik Behera from Bhopal. Friends, it's our proud privilege to have an excellent faculty with us tonight. What more DOA can ask for, and both President and Secretary of POSI are themselves sharing their vast experience and knowledge with us. I welcome all the faculty members and the delegates who have already joined and may be joining later on for attending this seminar. The session will be moderated by Dr. Ravi Chauhan, who has single-handedly organized this event today. And so I hand over to Dr. Ravi Chauhan for the scientific deliberations. Sir Ravi, please.
Thank you, sir. Good evening, everyone. So today we are here for the episode 4 of our DOA trauma series. We are successfully running our DOA trauma series, and in today's episode we are having the pediatric trauma, and we have invited very eminent faculty from all across India. So I'm really thankful for DOA for giving me this opportunity to moderate this session, and as well as I'm really thankful for Dr. Ashok Shyam, OrthoTV, who has provided the best platform to have it. So today we are having all of the executive body of our DOA as the panelists, and our faculty, which includes Dr. Dhiren Ganjwala. He is the current president of Paediatric Orthopaedic Society of India. He is currently practicing in Ahmedabad, Gujarat, and he is very well known for his pediatric orthopedic work all across India as well as internationally. He will be speaking on femoral neck fractures. Welcome, sir. Our next speaker will be Dr. Sandeep Padvardhan. He is the current secretary of Paediatric Orthopaedic Society of India. He is currently working at Sancheti Institute, Pune, Maharashtra. Sir is very well known for his arm board technique in supracondylar fractures, and it's our great honor to have him at this platform. So he will be speaking on supracondylar fractures. Welcome, sir.
Thank you.
Dr. Vikas Gupta, he is our Delhi faculty, and he will be speaking on lateral condyle fractures. He is currently working at Vardhaman Mahavir Medical College and Safdarjung Hospital, and currently heading the pediatric orthopedic unit there. Welcome, sir. Our next speaker is Dr. Pratik Behera. He is currently practicing at AIIMS Bhopal, MP. The topic of today's talk is fractures around the knee. So welcome, Dr. Pratik.
Thank you.
And at last, if time permits, I will be speaking. I'm Dr. Ravi Chauhan. I'm practicing currently at Sir Gangaram Hospital, New Delhi. And I will be speaking on some of the cases that have already been discussed. Some of the cases I will discuss and with panel discussion. So thank you. I welcome now Dr. Vikas Gupta for his lecture on lateral condyle fractures. Vikas, sir?
Yeah, I'm sharing my screen.
Yeah, please.
Is it visible?
Yes, sir. Please put it on slide mode and go ahead.
Is it okay?
Yeah, you can go ahead, sir.
Okay. So good evening again. And thank you, Dr. Vaish and Dr. Ravi for inviting me. And I'm going to speak about this lateral condyle fractures in children, a very important topic. Although it is the second most common elbow fracture, seen in children after supracondylar fracture, which Sandeep Bhai is going to speak, but it still remains the most common growth plate fracture around the elbow in children with an average age of around 6 years. But in spite of its being so common, it still continues to pose difficulties both in diagnosis, clinically, as well as radiologically. And the common mechanism of injury remains the fall on the outstretched hand, resulting in an avulsion fracture of the lateral condyle due to pull of the wrist extensors and supinator, which are attached to the lateral epicondyle. Now, with this basic knowledge, let's move into the classification. And we all are familiar with various classification systems described in the literature. But to make it simple and to make it better for understanding, I'll be discussing with you these three classification systems which are popular and easy to remember. So starting with the Milch, which is more of a morphological, although has a very poor prognostic value in terms of treatment decision. Now, what Milch did, he described a type 1 fracture which extends through the capitellar ossification center, that is lateral to the trochlear groove, which is an uncommon injury, but a more stable versus a type 2, which actually exits into the trochlear groove, and it's more commonly seen. The major distinguishing point between these two is the type 2 being unstable often leads to ulnar dislocation, the ulnar translocating laterally and proximally, giving an impression of elbow dislocation, which is actually not there. So type 2 remains the more common but more unstable. Although this classification is easy to understand and often remembered by our residents, but actually does not help us in planning our treatment. Now, the Vaish classification, which I think is the current preferred by most of us, is basically an extension of the Jacobs classification and is typically based on the displacement and the articular alignment on congruency. It is basically, the classification is based on the plain radiographs. However, there is a need for elbow arthrography for select fractures when we are planning for close reduction. I'll come to that. Now, simple to understand, a fracture which is displaced less than 2 millimeter and is presumed to have intact articular surface or hinge is classified as type 1. A fracture which is 2 millimeter or more with intact articular hinge is classified as type 2. And Vaish further stated that all these fractures usually have less than 4 millimeter displacement. And type 3 fractures are which are more than 4 millimeter, 4 or more than 4 millimeter with disrupted articular surface. So we have three classifications, 1, 2, 3, based on the displacement and the articular alignment. And it is still remains the preferred classification system for most of us who treat lateral condyle fractures. Now the question is, how useful is this Vaish classification? What are we gaining from it? It helps us to make a surgical decision. So according to Vaish, if any fracture which is 2 millimeter or more of this, having displacement of 2 millimeter or more, requires surgical intervention. Now, if you're planning a close reduction and pinning, you need to go for intraoperative arthrogram. So remember this point, that any fracture 2 millimeter or more will require some kind of surgical intervention. And any fracture which is 4 millimeter or more should directly proceed to open reduction, even without any preoperative or intraoperative arthrogram, as articular surface is presumed to be disrupted. So this has been validated. Now, how does this help? So type 1 fracture with intact articular surface can be treated non-operatively by a simple casting. Type 2 fractures, which is 2 and more than 2 millimeter with intact articular surface, can be treated by close reduction and pinning. Whereas any fracture which is more than 4 or more than 4 millimeter, which is presumed to have disrupted articular surface, will require open reduction. So I think this makes little sense. Now, finally, the Song described this classification based on the stability. He described various stages from 1 to 5. Now, though this classification refines surgical decision, helps us to make a better surgical decision, but practically it's more detailed and intricate. And I think for more practical purposes, we should use Vaish classification in our day-to-day practice. But if you compare Vaish with this classification, we'll see that type 4 and 5, song type and 4 or 5 will require operative intervention. Now, what about the imaging? How do you proceed? So for most of the pediatric elbow fractures, our routine is to get the AP and the lateral radiographs, and which are usually satisfactory if we can suspect clinically fracture to be quite displaced, and we probably don't need any other radiograph. However, having said this, most of the undisplaced and minimally displaced, as type 1 and 2, actually remain undiagnosed, or we don't get the true extent of displacement in typical AP and lateral view. So what Song suggested, that internal oblique view is essential for not only accurate diagnosis, as you can see in this fracture, which actually seemed undisplaced, and on internal oblique view, the displacement is more than 2 millimeter. So this internal oblique view becomes now an essential part of any pediatric elbow fracture, not only for diagnosis, but as well as to see the extent and to document the fracture displacement, which is defined as the greatest distance between the humerus and the lateral condylar fragment in any radiographic view. Now, what about the orthography? Actually, orthography has a major role if you are dealing with the pediatric elbow fractures. As you all know that pediatric distal humerus is primarily cartilaginous, and we all remember the mnemonic site, and they ossify at different ages. And trochlea especially ossifies at between the age 8 and 10. So most of the time, when we see the lateral condyle fractures, the trochlea is unossified. So the arthrogram helps us to delineate the fracture configuration. Basically, it helps us to see whether the preosseous cartilaginous hinge is intact or disrupted. And it's very important once we are planning for close reduction and pinning, especially in type 2 fractures, which seem to be minimally displaced. So when you see this radiograph, it looks very benign, but it may be that fracture line may be extending into the cartilaginous trochlea, which we can see during the arthrogram. So this procedure, although is simple, and we can approach the elbow joint through the triceps into the triceps into the oblique fossa, and the dye should be minimal, equally mixed with saline. But at times the interpretation could be challenging, especially for those who are not doing it regularly. Now, what about the higher imaging like CT, MRI, ultrasonography? Now, multi-detector CT, which is a refinement over conventional CT, is an effective tool, more accurate with minimal radiation, however, may not be accessible to all of us. MRI has its own downsides, especially the cost, sedation. The ultrasonography, I feel, is a promising and evolving tool, but it is skill dependent. So for most of the practical purposes, we rely on the good quality radiographs, especially the internal oblique view and the arthrogram, while deciding the treatment protocol. Now, coming to the main part, management. Now, non-operative management or conservative treatment in a long arm cast for 6 weeks has its own indications, especially for a fracture which is minimally displaced, that it's type 1, that is less than 2 millimeter in all the 3 views. Remember, in all the 3 views, if any of the view shows, especially the internal view shows more than 2 millimeter, then this will require operative intervention. So what you see, actually, you may not be measuring 2 millimeter, but fracture line is just barely perceptible. You cannot actually measure it. So we say it's less than 2 millimeter, assuming that articular hinge is intact. Like this fracture, which the line is just visible. And if in doubt, that if you're planning to do conservative management, and if in doubt about the articular hinge, you should confirm by arthrogram or by preoperative MRI. And make sure that the soft tissue shadow or integrity is normal. There should not be excessive soft tissue swelling, which signifies unstable fracture. But friends, if you're planning to go for conservative treatment, you have to remember certain things, that these children must be followed meticulously by and should get weekly radiographs every week for at least 3 weeks to look for any secondary displacement, which is not uncommon. The question is, should you remove the cast? What I feel, if you are given the Scotch cast and if you can visualize the fracture line, you may not remove it. But if in case any doubt, get the cast removed and get the radiograph. All the 3 views. As this Kapnick has shown that 14 to almost 15% of fractures still displaced in his series on conservative treatment, as this X-ray has also, as you can see in this X-ray also. So this is an example where the child was managed in a long arm cast and united well, and post-op X-ray shows no complication and well union. Now, what about the operative management? Now we have two options: closed reduction and internal fixation, and open reduction and internal fixation as the choices, depending on the displacement and the articular hinge involvement. But the foremost goal, whether you are doing closed or open, is to restore the articular surface anatomically. So that remains the foremost goal of lateral condyle fracture management. So indications for operative treatment is any fracture with 2 or more than 2 millimeter of displacement in any view remains the foremost indication. Unstable fracture, like any fracture with extensive soft tissue injury, and failed non-operative treatments, like fracture I showed you that displacing in a cast. So these are the few indications of operative management. So beginning with this closed reduction and fixation. Some of you may not be familiar with this technique, and this is only indicated in subset of patients, this closed reduction and pinning, where fracture is 2 or more than 2 millimeter of displacement, but the articular congruency or the cartilaginous bridge is intact. If you are sure, it is especially if you are sure by getting MRI, or make sure that if you are planning to go for closed reduction, you confirm it by intraoperative arthrogram. So this is a rider that if you are planning closed reduction, make sure that articular surface remains intact. The arthrogram, the reduction is done by simple varus stress with elbow extended and forearm supinated, and the maintenance of reduction is done similar to what we do in a open reduction with 2 or 3 parallel smooth K wires. Like in this case, where X-ray, the arthrogram shows that articular surface is intact with no extravasation or dye into the joint. The Song and Mincer have shown good results in approximately 60 to 73% of the cases using this technique of closed reduction and pinning. However, they have also stated that technique is difficult with a learning curve, and specially cautioned that if it fails or you are unable to do closed reduction, go for open reduction. So what about the open reduction and fixation? Remains the procedure of choice for most of the lateral condyle fractures. So the foremost indication is any fracture with 4 or more than 4 millimeter of displacement in any view, one should directly proceed to open reduction without any other investigation like MRI or arthrogram. So any fracture with articular incongruity, if confirmed by arthrogram or MRI, also becomes an indication for open reduction. And any fracture which has failed closed reduction, like you're trying for closed reduction, which has failed and becomes an indication, you should go for immediately open reduction. So the approach is simple, through a lateral incision and following the brachioradialis and triceps interval. And to make it simple, the 2/3 of the incision usually lies proximal to the joint line and 1/3 distal to the joint line. But those who have done it, they will remember that in a fresh fracture, the deep dissection is already done by the traumatic event with a rent in the fascia and the brachioradialis musculature leading directly to the fracture surface. Make sure you open the capsule anteriorly so to view across the joint. And remember the anatomy, especially the vascular anatomy, and avoid dissecting these soft tissues posteriorly, because lateral condyle and the capital or ossific nucleus have an end arterial blood supply, and its damage can lead to osteonecrosis. the fragment, actually what you see intraoperative, is always greater than is apparent on the radiographs, because that is partly cartilaginous. And few tips: use a long narrow retractor, especially to view across the joint. So retracting the tissues up to the end of to the medially, and the headlamp becomes very important, very useful tool to aid, to help in the visualization of the articular congruency. And remember, the articular alignment takes precedence over metaphyseal adduction, where, because there could be termination, or the metaphyseal adduction is not important in acute fracture, and articular alignment should be maintained at any cost. Now, reduction is assisted by either reduction clamp, or you can always use percutaneous pins as a joysticks, and once reduced, you can pass it across the fracture site. Now, the goal of distal humerus surgery, for any surgery, I'm not saying for the lateral condyle, is to restore the triangle of stability as shown in this paper. And if you're planning for K-wire fixation, preferably they should be bicortical with adequate divergence. So when you're fixing this fracture, the first pin should be in the transverse column, parallel to the joint line. This is mainly cartilaginous column and may not be very rigid fixation, but definitely gives some stability. And preferably it should be unicortical to avoid irritating the adjacent ulnar nerve. The second pin should be aimed at the medial metaphysis, preferably at an angle of 60 degrees. And add a supplementary fixation, a third pin, if you see that fixation is not as strong as you want. And recent studies have shown that a metaphyseal compression screw has a lower complication rate, and you can mobilize these fractures much earlier than pins. However, it has its own downside and require, again, repeat surgery for screw removal. Now I'll show you some of the cases. This 7-year-old boy who was referred for actually casting, looking at his X-ray, he was advised a simple above elbow cast. But if you see closely his elbow, the soft tissue swelling, and then I ordered the internal oblique view, you can see that displacement is definitely more than 4 millimeter. So you don't go for any kind of advanced imaging or even intraoperative arthrogram in these cases. So what I did, I proceeded to open reduction, and the fragment was grossly displaced and was fixed following the principles of K-wire fixation. And he had a good, excellent result, followed after 6 months with good alignment and no complication. Now, as compared to other elbow fractures, the lateral condyle fracture has many complications. I'm not going to discuss all of them, but briefly I'll share a few of them, starting with the most benign and the commonest complication, that is the lateral spur or prominence, and that is due to bone formation under the elevated periosteum. Now, this complication in some of the series is seen almost in 100% of cases, irrespective of the type of treatment, whether conservative or operative. However, this presents as a varus, which is actually called a pseudo-varus deformity, because there is no change in the Bowman's angle, which you see after a malunited supracondylar fracture. Though it can be significant at times, there is no functional impact. The child has no disability, so there is no intervention is done. But important thing is family should be adequate counseled beforehand. What about the osteonecrosis? Now, this could be a devastating complication, especially due to extensive dissection and soft tissue stripping once you are doing to reduce the late presenting fractures, as well as it can be seen in a fresh fracture if you are doing multiple reduction attempts and dissecting vigorously. And the condylar fragment AVN can lead to a non-union with marked stiffness, and the AVN of the trochlea can lead to this radiographic appearance of fishtail deformity, deepening of the trochlear groove, which may not have any significance. Growth disturbance can present as a varus or a valgus deformity, which, however, most of the time are asymptomatic or at times may present with minor symptoms. But what I want to share with you in few slides is the late presenting lateral condyle fractures, which we see very often in public sector hospitals. And in spite of that, there is no definite treatment guidelines and remains a challenging problem. However, from treatment point of view, they can be distinguished into two types: a delayed presentation, which present within 12 weeks after injury, and non-union, which present after 3 months with no bony union or pseudoarthrosis. So fractures presenting with delayed union should go with internal fixation, as shown in this paper also. A number of studies have shown by careful open reduction and internal fixation. However, managing a non-union is a very challenging problem, a difficult dilemma, and management is dictated not by the duration or by the X-ray, but it's dictated by the symptoms the child is having. So I'll show you a few cases. This 9-year-old girl presented at 6 weeks, and you can see she had weakness with restricted range of movement. So after open reduction, she has full range of movement and good outcome. If you see the outcome score, Dhiren or any other score, she has a good outcome. However, one can see a pseudovarus deformity. Another boy presented at 2 months, underwent open reduction with almost normal looking elbow. This 9-year-old boy actually presented quite late at 9 months, mainly with pain and instability. So we went for in-situ fixation, similar to what we practice in slip capital femoral epiphysis without disturbing the blood supply. Now, briefly about what is in-situ fixation, which is a novel concept popularized by Flynn, where we go for metaphyseal healing or metaphyseal alignment, unlike fracture where we go for articular alignment. So no attempt is made to align the articular surface. One can use the pec graft if the gap is large, and this in-situ fixation basically helps in gross realignment of the distal humerus, which improves not only elbow motion and addresses the subsequent valgus instability, which the child can develop later on. Now I'll show you a few examples of in-situ fixation. This 11-year-old girl presented at 9 months, and you can see the X-ray. It was grossly displaced. She had complaints of abnormal prominence, pain, and as expected, restricted range of movement. One may think of leaving it as such, but we went ahead with in-situ fixation with minimal mobilization. And you can see the intraoperative picture. The fragment was grossly rotated, but the fragment united well. And you can see the radiographs. So she just came out few weeks back, where we removed the screws. She had almost complete range of movement, and she is now pain-free. And though there's some prominence is there, but her range of movement has also increased. And this is the last case where this girl actually presented with a valgus deformity. Her concern was cosmetic. Though there was no pain, the movement was almost full. So in these cases like this, with valgus deformity, the aim is to correct the deformity. So what we did was step cut translation osteotomy, which we have been doing in a cubitus varus also. And the deformity is well corrected, though we didn't try to fix the fragment as such, because she didn't have any symptoms related to the fragment. And you can see the result after 2 years, she's doing well. So in summary, the salient points one should carry home for my talk is that it is recommended to get internal oblique view in any, I would say, in any pediatric elbow injury, and especially if you're suspecting lateral condyle fracture. Because of this intra-articular and transfacial nature of this fracture, lateral condyle fracture results in high complication rate, and every surgeon should remember this. And the last is, and very important, that any fracture with 2 or more than 2 millimeter displacement, visualized radiographically, should undergo operative fixation with a low threshold for open reduction. So thank you, friends.
Thank you, Vikas sir. It was an excellent presentation with such an excellent demonstration of the cases, as well as the covering of late presenters, as well as the non-union, which and every orthopedic surgeon should know. So now the panel is open for questions. Are there any questions from the panel itself?
Ravi, can I ask a question? This is Dr. Lalit.
Please, sir. Please go ahead, sir.
Yes, sir, yes.
So, Vikas, excellent presentation. For the benefit of the viewers, can you describe the internal oblique view a bit more? Is the elbow kept in flexion or extension? How do you do this X-ray?
It is about 45-degree internal oblique view.
And it can be done
partly
both in
flex-
extension and flexion?
No, it's partly flexed in extension only. If I'm not wrong, it is around about 45-degree internal oblique view, and it is extended.
Okay.
Because the thing is, Lalit, that in a acute fracture, you may not be able to extend or flex the elbow much. It's quite painful.
Yes.
So I think it is the best position in which the child is comfortable. You go for 45-degree internal oblique.
Thank you.
This X-ray is usually done before applying the plaster, sir. Actually, so before applying the plaster, elbow is usually kept in sort of 10-degree flexion or 20-degree flexion, not more than that. I think.
I would say that whenever you're suspecting a lateral condyle fracture, you should get, I think you should include a internal oblique view for any fracture around the elbow, because you may not be suspecting, you may not be looking clinically at a lateral condyle fracture. So I think it should become part of our daily routine. And I'm a resident, I think our residents should learn that getting internal oblique view helps us to make a proper decision.
This fracture is most commonly missed actually during day-to-day practice in most of the time, especially when the displacements are less than 2 mm or even equal to 2 mm or like that.
I think, you know, that I personally see more of missed fractures than the acute fractures.
Yeah, definitely, sir.
And the commonest reason I see is that the patient either given a cast for undisplaced, or I would say minimally displaced fracture, which has secondarily displaced, or most of the time they are presenting late.
Yeah, definitely.
Late to us due to multiple reasons.
Ravi, can I ask a question?
Yeah, please, Samir, sir. Please go ahead.
Hello, Dr. Vikas. Kya haal hai?
Hello, sir.
Very nice presentation, sir. In the last case that you've shown of a girl of 9 or 11-year-old, where there was extreme valgus and you'd done a step cut hysterectomy.
Yeah.
Sir, what is your experience with in such cases with extreme valgus and tardial palsy along with it in many times? How's your experience with Milch opening wedge displacement hysterectomy, where you leave the fragment alone, just do a varus correction and leave it alone?
If I'm not wrong, you are asking that how, the experience about the Milch osteotomy. Dr. Samir?
Dr. Samir, your actually voice is not clear. There is some issue with your connection.
Yes.
Dr. Samir, can you?
Okay.
Okay.
Voice?
Samir, sir,
Ravi,
can you type your question in the chat box?
Is it better?
No, it's
Milch.
okay. I think I've understood his question.
Yes, I'm asking about Milch.
Yeah.
Yes.
Let me answer your first question about the ulnar nerve transposition. So when we are correcting this severe valgus, actually we go for the ulnar nerve transposition also. But when you're correcting the deformity, the ulnar nerve actually also gets relaxed. But since it is long-standing and but we make it a point that if ulnar nerve symptoms are there, we make it a point to transpose the ulnar nerve anteriorly. Regarding your second question about the Milch osteotomy, actually, maybe during my residence, but done and published this technique of step cut translation osteotomy, we have found our results very promising, and with, I would say, no but minimal complication. Basically, it follows the principles of deformity correction, because you are correcting the deformity not at the cora, but proximal to it. So there is some minimal translation which you do to align the humerus or to align the upper limb. So my experience with step cut translation is good, both for varus as well as valgus. The technique is not difficult, but what you need is a customized L buttress plate. And I hope if you read the original article by Kim, this the it will be clear to you that why this technique is getting popular.
Are there any other questions?
Yes, sir.
Okay, thank you, sir. I've done a few stereotomies.
I think Dr. Sameer has some issue with the internet connection. Vikas sir,
Yes, sir.
my question is that in your presentation you have mentioned about the 6 weeks cast for the non-operative cases, and you have mentioned that after 3 weeks you require to remove the cast and then go for X-ray.
Not 3 weeks, weekly. I think just let me clear it. If you're planning conservative treatment, you make sure that there should not be any secondary displacement, which has been shown in a number of studies varying from 10 to about 25%. So if you are given a cast, call the child next week for an X-ray. Now, X-ray can be done either within the cast if you are using a Scotch cast, because that makes the fracture, you can visualize the fracture line in the cast. And if in doubt, fracture line is not visible or it is hazy, it's better to remove the cast. Because if you are presuming that fracture is stable, removing a cast will not hamper it. So you have to get the cast, the X-ray weekly for 3 weeks, because it is assumed that by 3 weeks, the fracture has stabilized. There is a callus, minimal callus formation, which will not further displace the fracture. And probably this holds true even for the both bone forearm. If you are treating a both bone forearm conservatively, you should get the weekly X-ray till 3 weeks, I would say till 3 to 4 weeks, to look for any displacement or rotation. This has been proved in the studies also.
Okay, thank you, sir. And sir, one more question. In case of malunited supracondylar fractures, what's your take on the lateral condyle fractures?
No, you're saying supracondylar or lateral condyle?
Malunited supracondylar fractures when they present with lateral condyle fractures.
Yeah. I have few cases.
I came across few of the cases actually. In those cases, I find it difficult even on the internal rotation views.
No. A case because last time I think in one of the forum I showed you, malunited supracondylar basically whereas deformity predisposes to lateral condyle fracture.
Yeah.
And most of the fractures are displaced. And then you have two options: either to correct the deformity simultaneously and fix the fragment, or you fix the lateral condyle fracture. So what I did in one of my case is I corrected the deformity with translation osteotomy and fixed the lateral condyle fragment. So I think it could not show this case, but this is the common scenario or common complication of a malunited supracondylar fracture.
Yeah, definitely.
But it's not so common. It has been described, but not so common, but occasionally seen, I would say.
Yeah, actually, a few days back, I came across one of the malunited supracondylar fracture with cubitus varus and presented with lateral condyle fracture, but it was minimally displaced. Not that much displacement.
I think internal view, that should not be a problem.
Yeah, I find it very difficult. Then again, I sent for X-ray and then got it.
I think in that case, you should go for MRI if possible, or arthrogram.
Yeah, thank you, sir. So, are there any question or can we proceed for the next presentation? Okay, then now we can proceed for the next presentation. Our next presentation will be by Sandeep sir, Dr. Sandeep Padvardhan. He will be speaking on supracondylar fractures. Sir, please.
Yeah. Thank you, Ravi. Can you hear me well?
Yeah, sir, you are audible.
Okay, so I'll just share the screen. Again, I'll make it full screen. All right, you can see that?
Yeah, sir.
Okay, so thank you very much, Delby Orthopaedic Association, for involving me in this lovely symposium and lovely talk by Dr. Gupta as usual. Thank you, Dr. Srivastav, Dr. Vaish, and Dr. Chauhan for inviting. So supracondylar fractures in the children, in the next 12 to 15 minutes, I'll try to cover a really big topic, because I was telling Ravi that I can talk about 1.5 hours on this, but that then would go beyond the scope of this webinar. What you should know is that this is the third most common pediatric fracture and the most common elbow fracture. 75% of all elbow fractures are supracondylar fractures. It is the most commonly operated pediatric orthopedic fracture. However, it has another dubious distinction. It is the most common cause of litigation in pediatric orthopedics. And that comes as a warning. If you look at this paper, misdiagnosed supracondylar, highest number of cases with the payout, which was the largest, and malunion or nerve injury during surgery for a supracondylar fracture. So these two form a bulk of litigations if you don't manage these cases correctly. It is the T20 season, and instead of watching the cricket, we are seeing pediatric fractures. So let me put it in the T20 perspective. When you see a supracondylar fracture, what should be your first look? Like in sports, immediately you should look for whether there is a nerve injury. Always make sure that your X-rays are covering the next joint, because lower end radius epiphyseal injuries are commonly associated with supracondylar fractures. Don't miss those. And always look for a flexion type of injury. Not every fracture of the supracondylar region is extension fracture. So your first look should look at, is there a pointing index? What is happening to lower end radius? Is there a flexion injury? The next thing you should look at is the skin. Is there a pucker sign? And what is happening to the medial spike? Is it subcutaneous on the medial side or on the lateral side? Because that is one of the indicators of irreducibility. And your mind should keep preparing for an open reduction when this sort of a thing happens. So this suggests difficult reduction and possibility of entrapment. The last thing you should see is there a contusion on the point of the elbow? If there is a contusion or a wound on the olecranon, probably you're looking at a flexion type injury, which is about 5% to 7% of all cases, but it is the most common cause of missing it, and it has an ulnar nerve injury along with it. So the first look should rule out all this immediately. Do a quick nerve test, the OK test for the median and the ulnar nerve. If the child can make his index and thumb touch each other in flexion, or make an OK sign, A1 or OK sign, median and ulnar are usually OK. Ask him to do thumbs up, that tells you radial nerve is OK. And if the index is pointing, then probably anterior interosseous nerve is injured. And that is the most common nerve injury with a supracondylar fracture. What about a vascular evaluation? Look for perfusion. Pulse may or may not be palpable with the swollen forearm and elbow. Look for capillary refilling. Look for stretch pain. And only if necessary, you can put a pulse ox or get a Doppler. CT angio is really not required, doesn't add value. Pulse oximetry and your waveforms should be enough. Next, get decent quality X-rays. Look at this. This is an X-ray which was done and the child was treated and given a plaster and sent away. And this was an X-ray in slab after 1 week. You can make out hardly anything. This is not the kind of X-ray that you need to diagnose correctly what is the elbow injury. And when it was removed, it was a lateral condyle fracture. So as Dr. Gupta said, our standard prescription for any pediatric swollen elbow has to be AP, lateral and internal oblique without a plaster, a good quality X-ray. Don't make your diagnosis on suboptimal X-rays and treat children. Always, when you take an AP view, ask for lower humerus AP rather than elbow AP. Jones view is very difficult to take, whereas if you ask for an elbow AP, you get something like this. We call it the loser's view, because the radiologist or your technician centers on the elbow and you see neither the lower humerus nor the proximal ulna or the radius, and you may miss a lot of fractures. Focus on the lower humerus. On the lower humerus, on a plain X-ray, remember the Norrell's fat pad sign. The supracondylar fracture, there are 2 fat pads in front and back, and subtle injuries, you will see displacement of these fat pads, which tell you that there is a supracondylar fracture here. And it is very important, because if you send away such a child without diagnosing, as I said, he will go to your colleague or it gets displaced and you are then prone for litigation for missing a type 1 supracondyle. Always draw the lines when you are in doubt. The anterior humeral line must intersect the lateral condyle in the center or the capitulum, because the distal lateral condyle is tilted 40 degrees anterior. So when you draw the anterior humeral line, it usually bisects from the center of the capitulum. If you do not see the bisection and the anterior humeral line is going anterior, then your fragment has got tilted posteriorly, which means type 1 supracondylar. If it is going posterior on the lateral condyle, that means the fragment is flexed. So probably you have a type 1 flexion injury. So drawing the anterior humeral line, looking at the Norell's fat pad signs are very, very important indicators so that you don't miss a type 1 injury. In the coronal plane, look at the Bowman's angles and draw the Bowman's lines so that you know what is the angle. Normal is about 65 to 80 with a mean of 75. When you have a displaced fracture, you know that the fragment is in varus tilt. And you must attempt to reduce this so that there is no residual cubitus varus deformity. Column views are for C-arm imaging to look at stability, and we'll talk about them later. The second over, what are you going to do? Type 1 fractures or grade 1 fractures are easy. You put them in a simple immobilization in a slab or a cast and send them away. But beware. And why beware? Because they can be deceptive. A type 1 supracondylar with a medial comminution or a slight varus tilt, which is also called as a grade 1B, will come back with collapse and a bad cubitus varus deformity, especially if the child has hyperlaxity. Because of recurvatum in the elbow, the varus looks more pronounced and more ghastly. So a type 1, please look at the medial column. Is there comminution? Is there impaction in varus with a tilt? Because that needs to be corrected. An example of a type 1 injury which healed in varus with a bad deformity. So beware of the type 1B variant where you can have this kind of a complication. Type 2, again, conventional teaching was type 2 can be conserved, but you have to be very careful to classify it. This type 2 injury now has been subclassified by Wilkins into type 2A, where there is no rotational malalignment, and type 2B, where there is rotational malalignment. If you see the distal humerus as if you are seeing AP on a lateral view, it means there is a rotational component, though there may be continuity of the posterior cortex. The type 2B fracture, which is rotationally unstable, will need reduction and pinning. So this is the difference between type 2A, where the width of the proximal fragment and distal fragment are usually equal. This has been measured and published by a person called Gordon, and is called Gordon's index. But to put it simply, when you take a dead lateral view, the proximal humerus is seen like AP and the distal humerus is seen like lateral, even though you feel there is posterior continuity. And this is usually a type 2B rotationally unstable fracture. Also remember, there is one more variant which is described, which is type 4, which is described by Leash. And this is where the periosteal hinge is broken circumferentially. And it is extremely unstable in flexion as well as extension. What it means is that it comes as an extension fracture, but when you flex it, it goes into flexion. Normally, the posterior periosteal hinge should prevent this from happening. Bach has also classified fractures depending on their level and obliquity. So be wary that this is also important. Where is the fracture line? Is it a very low supracondylar? Is it a high supracondylar? Is it a medial oblique or is it a lateral oblique? Because your pin placement depends on how much bone stock you have. And in the sagittal plane, is it oblique or transverse? Because an oblique fracture going from back to front may need a pin which goes from back to front perpendicular to it. So these are the variables which should be noticed and known by all orthopedic surgeons. Don't just assume a supracondylar to be a straightforward job. So these are the variations. This is a standard transverse supracondylar. This is a lateral oblique. As you can see, the obliquity is giving you a larger lateral chunk of bone. So all wires have gone laterally. If you have a medial oblique like these, exactly reverse, you will need to pass the medial pin. Otherwise, we normally don't pass a medial pin nowadays. You can have a high supracondylar where the purchase may be pure and you may poor, and your pin may go intramedullary, and you may need to have a fixation, something like this. In high sagittal fractures and high oblique fractures, and low sagittal fractures. So depending on what is happening on the X-ray, you must be very wary. The fifth point, or the fifth over, change in strategy. So if you have a rotationally unstable type 2B fracture, please go for close reduction and internal fixation. And the type 3 supracondylar, moving on to the next type, is your standard. So that is the gold standard. Sachin and Bradman for you there. And cross pinning has stood the test of time. However, I pointed out that ulnar nerve injury is almost always purely iatrogenic. Very rarely is because of flexion injury. And if you can avoid the medial pin, it's better, but there will be situations where medial pinning is necessary. When you plan your surgery, make your arrangements correctly, put the C-arm in the right place, the trolley in the right place, the monitor should be facing you, position the patient correctly, which brings us to positioning. Most of you will use a big arm board like this or a hand table on which you put the hand. Now that length of the board makes it difficult for you to pass wires because the board comes in the way. So what you need to do is put a lateral, small folded sheet or a bump underneath so that you have access all around for maneuvering and putting your pins. To obviate this problem, this is how people do it. I have my own arm board technique, which I have talked about and published it. So this is the arm board technique where we will put the arm board at the edge. And I don't know why the videos are not working. Can I go back and enable the videos?
Yeah, please, sir.
Sorry about that. I don't know what happened. Because when I checked them, everything was working. Surprising. Okay, I think I'll just run the video technique for a moment here. We'll rush through it. Can you see? Sorry. Just a moment. Yeah. Okay. Can you see the video now?
Not yet, sir.
Yeah, I'm playing it. Can you see this?
No, sir. Video is not moving actually forward. Not yet.
Yeah.
Yeah.
Are you able to see?
Yeah, yes.
You'll have to narrate it, sir. There is no audio here.
Oh, sorry. I'll enable the audio again.
Yes.
Yeah. Just give me a moment. Sorry for the delay. Oops, sorry. Ashok, just give me a moment. I'm making some errors in sharing. Okay, I think you should hear it. Good morning. This is Dr. Patwardhan, Pediatric Orthopedic Surgeon from Sanchiti Institute, Pune, and I am presenting to you our arm board technique for close reduction and pinning supracondylar fractures in children. Conventionally, supracondylar fractures are reduced and pinned in the following positions: with the elbow on a hand table, where sometimes manipulation of the distal fragment becomes quite difficult, and after that, pinning requires a free access around the elbow, and the table actually comes in your way, and the drill keeps on hitting that while passing the KY, so it's quite tough. You can use another method where people keep the elbow on the C-arm tube itself, but the cleaning solutions can seep into the C-arm equipment and can damage equipment and cause problems. Some people do reduction and pinning in the lateral position, but getting an orientation of varus and valgus is quite difficult when the patient is in the lateral position. You need an assistant for traction, counter traction. And when you need to see the lateral view, you tend to externally rotate, which causes the reduction to slip. So we have our own way of doing this supracondylar reduction, which we will demonstrate. This is a preoperative radiograph of a type 3 supracondylar with a brachialis perforation and a pucker sign. That's the ecchymosis as it is seen. This is the picture of the arm board. It's simply a wooden board of about 1 inch thickness, which is radiolucent, painted with a simple oil paint, and is about 4 feet in length. Preoperatively, always check the capillary refill. Now the arm board is positioned thus that the proximal fragment is strapped with a transport or a hypoallergenic paper tape. The distal fragment is off the table, off the board, and with a gentle milking maneuver, we can reduce the fracture. You can see that pucker sign disappear, and you can see that the distal fragment is completely free and it's outside the board. I do an AP check and confirm my coronal plane alignment, and then we make the C-arm rotate by 180 degrees to look at the lateral profile. I don't need an assistant because the tape provides counter traction. I can reduce the fracture. I can check a true dead lateral in this position, and this allows me complete 360-degree access for pinning. After appropriate preparation, antiseptic lotions are applied and draping. The first pin is passed through the fossa in the lateral profile with the elbow flexed, maintaining my reduction. I pass the first pin from slightly anterior towards posterior, and that goes through the fossa, which is the forecortex pin. Then I turn the C-arm by 180 degrees to look at the AP, confirm the position of my pin, and the second pin is now placed parallel about 8 millimeters away from the first pin through the column. So we have a column pin and a fossa pin, and you can see the ease with which I can do the procedure without any real assistant or traction counter traction. I can then rotate in external rotation to confirm rotational stability, which you can see is very good. And then I take obliques, the internal and external oblique views, to look at column position. Then I bend the pins and cut the pins, leaving a centimeter out for extraction later comfortably. After which, a cast in the comfortable position by checking the capillary. Pinning can be made very easy, and you can achieve consistently results like these extremely easily without any damage. In case of difficulty in reduction, joysticking is also possible with this, and we can just push the arm board a little further if I need to do an open reduction from the anterior approach. So I'll just go back to the presentation here, and can you see this?
Not yet, sir.
Not yet. Sorry. Yeah.
Yeah, it's coming now, sir.
Right. So we went through the arm board technique. So I'll just skip all those slides. So why were we fussing about the reduction so much? Because you must realize that the columns, unless they are aligned, if there is a rotational malalignment, we are not worried about rotational malunion. But in a rotational mal position of the column, it collapses into varus. That is the real importance of not accepting it. And that is what you should know, that when you are having a situation of rotation like this, as you can see, the columns must sit on each other. If they are mal rotated, they will collapse into varus. So that is the beauty of keeping the columns intact and getting a column view for your reduction. So column views are very important. I told you obliques, and on the lateral, again, as I said, the width of the diameter of the proximal and distal fragments. You shouldn't accept anything that looks like this, which is the fishtailing or the AP view on the lateral. Some troubled situations, difficult reductions, as we said, sometimes if you are not using the armboard technique, when you rotate on the rotation, the reduction slips. So what you can do here is you try to reduce in the lateral profile. You rotate the arm externally and bring it into the lateral profile, and then you do your gentle reduction by flexion. So you will have to manipulate the proximal fragment into external rotation. Otherwise, when you try to do external rotation, your fragment displaces. So reduction in the lateral profile and get the proximal humerus to a lateral view, and then align the distal fragment to that and lock it in flexion. So that is what can be done. Second, if there is a soft tissue block to reduction, if the milking maneuver doesn't work or there is buttonholing, as I said, you can make a small anterior incision, just release the buttonhole and push the proximal fragment back in. There is one more method which has been published by Viraj Shingade from Nagpur. Large swelling and displacement like this, he uses a suction cannula. You make a small anterior stab incision and push the suction cannula as a lever, connect it to a suction so that the hematoma gets sucked away. And against that, you do the reduction using that as a counter pressure. So you can see that suction cannula is pushing the proximal fragment behind, and then he reduced it against the suction cannula. And then when you get your reduction, you pin it. And that is the pinning that was demonstrated. Sometimes you get the flexion injury. Now, flexion injuries are more difficult to reduce and pin. Should you do the reduction in extension or flexion, and how do you pin it? So there is a technique described again by Fletcher and Bruce, use of a trans-olecranon pin for flexion type of supracondylar. What you should do is the reduction has to be done in extension. So in 70-degree extension, you will get your reduction, but question is how do you pin it? So what you do is you pass a 1.8 mm, a thinner wire, which goes through the olecranon into the distal fragment and then into the canal of the proximal fragment. So in extension, you have achieved reduction with an intramedullary wire, which is going trans-olecranon and through the distal fragment. Then what you do is you shift your C-arm to the AP. On AP, this is thin enough, and since it is intramedullary, it can toggle. Then you adjust your coronal malalignment and then put your definitive fixation pin. Once the fixation pin is in, you remove the trans-olecranon wire. And this is the final picture where you will get a very good reduction in AP and lateral. So this flexion injury is slightly tricky, but you must be suspicious if you have a contusion on the elbow, on the olecranon, or you have an ulnar nerve palsy or ulnar nerve symptoms. What about pin placement? Cross pinning has always been the gold standard for stability, but the world has now moved towards lateral pinning because of the litigations and ulnar nerve injury, which is iatrogenic. Cross pinning seems to be more stable, but now it has been proven that if you have the forecortex pin and the column pin, it gives equal stability. And it is safer, more convenient, and you can avoid the ulnar nerve complications. The only issue is if you have a medial oblique fracture, you need to put a medial pin. So that is what is important. Lateral pinning, the world has moved from 2002, where we said 2 column pins, to now divergent pins where 1 pin should go through fossa and 1 through the column. And if there is additional rotational instability, Skaggs has recommended a 3rd pin to stabilize the fracture in large elbows. So when I say a fossa pin, what do I mean by a fossa pin? A pin that goes from the lateral cortex, comes out through the olecranon fossa, and then goes back through the fossa and comes out on the medial side. So this is the fossa pin. It's transarticular. It will block movement, but it is there only for 3 weeks. You're going to remove it and then allow motion. So it doesn't matter and doesn't cause any additional complication. So you should be aware of that. Direction of the pins we have spoken about. The medial pin is usually anterior to posterior, and try to maintain the 40-degree anterior inclination of the lateral condyle. If you want to pass a medial pin, how do you do safe medial pinning? Indications are instability after lateral pinning, rotational instability, or a medial oblique fracture, or with medial impaction or comminution, where you need to disimpact it and then hold it with a medial pin. Even pinning the ulnar nerve sheath can sometimes cause palsy. So it's important to avoid pinning the ulnar sheath also, and safety comes with pinning in extension. So you pass the lateral pin first with your thumb, you push the ulnar nerve behind, and your pin should be in front of your thumb. Pin in with the elbow in relative extension and drive the pin from front to back from the medial epicondyle. If in doubt, make a small opening. You don't need to dissect the ulnar nerve. From where you are putting the pin on bone, make sure there is no nerve there. Put a drill sleeve so that you don't entangle the nerve sheath, and then pass the wire. So it's as simple as that. In a pink pulseless hand, the 17th point, you must know what should be left alone and what needs intervention. Commonly, you will see absent pulse with good capillary circulation. Even if there is no pulse, a Doppler can pick it up. But if the hand is perfused well, the pulse may not be there, but perfusion is important. Whereas it is pale and pulseless, obviously you will need to explore. Even after pilling, if your hand remains pale without a pulse, explore. But if it is pink, what is the rational approach? Admit the patient. It is reasonable to monitor carefully for 48 hours. If the perfusion of the hand is good, pain reduces, there is no anxiety, no agitation, no increasing requirement of analgesic, you can leave the patient alone. If perfusion deteriorates in 2 days, pain worsens, there are deepening signs of a neurological picture, exploration is mandatory. So what is rational is pink perfused hand, observe for 48 hours and then discharge. Don't send them away on the same day. So close reduction and pinning, document the lesion with Doppler, watch for the 3 A's, that is anxiety, agitation and analgesic requirement. Counsel the parents about necessity of opening if required. Observe for ischemia or deepening nerve palsy in 48 hours. If these are there, have a low threshold to explore. Otherwise, a pink pulseless hand, you need not interfere with it and adapt to your local circumstance. What about nerve injuries? Pointing index is the most common and it usually recovers. Radial nerve and medial ulnar nerve are rarely injured, but you should be cautious. If there is a nerve injury pre-op, document it. If you can get a good reduction, just observe, it will recover. If there is a nerve injury and when you do reduction, there is a gap or there is a mushy reduction, or if it is irreducible, probably the nerve is getting trapped, then you explore. If there is an open fracture, obviously you will explore. And if you have developed a palsy post-pinning, it was not there earlier, obviously remove the pin and revise your pinning and may require exploration. If there is a combination of a vascular with nerve and with a pink pulseless hand, you don't get adequate reduction, please explore. Be safer than rather than sorry. And this is an example where there was an entrapment of both vessel and nerve in the fracture, and an open reduction demonstrated that obstruction, and that had to be relieved before pinning. When do you do open reduction? When there is a failed close reduction, revision surgery, neurovascular injury, open injury, and very often in our country for late presentations. The recommendation is not to go posterior, go where the proximal spike is. If the spike is anterolateral, take an anterolateral incision, remove whatever is obstructing and do a close reduction. If it is anteromedial, take an anteromedial incision. Posterior approach is rarely required. It causes more triceps adhesions and fossa fibrosis, leading to stiffness. So finally, the last winning points, type 1, type 2, close monitoring, especially for displacement. Type 2B, type 3 and type 4 are unstable. They require close reduction and pinning. Anatomic reduction and acceptable reduction are mandatory for a good outcome. If you have failure of reduction or there is interposition, do not hesitate to open. If there is a primary neurovascular problem, open fracture, severe swelling which is not reducible, or you are in periphery where you don't have CIAM, no IITV, or you are not confident, go ahead and do a good open reduction rather than struggling. So this is what is recommended. It's important to have a hit rather than a miss in supracondylar fractures. Thank you very much.
Thank you, sir, for such a nice presentation. I think for supracondylar fracture, whole day will be less, and Sandeep sir can speak for more than few hours on supracondylars.
Yeah.
So, are there any questions for Sandeep sir? Anybody from panel?
Ravi, can I ask?
Yeah, please, please, sir. Please.
You are very right. I think it'll take most of the night, till morning. We'll still be discussing supracondylar. There's so much to know. But I think I've learned a few things, beautiful things here that I never knew, Dr. Sandeep Padvardhan, sir, that you could put a fossa pin. I never learned that. I never knew that. So that was something new for me. So I would want to ask, sir, you are a trained pediatric surgeon, but many of us are not pure pediatric surgeons, and we are general orthopedic surgeons, and we do get cases, and we do have to operate on children. So can you just tell us about pros and cons of closed reduction and pinning and an open reduction and pinning? Because I find many times I'm struggling, in a closed reduction, doing all kind of maneuvers and then taking very long and then pulling and pushing and all that stuff. But I find an open a very easy thing in children, and fixing it, and they're right in front, and I'm satisfied, and the child does good. What's your opinion on that?
So, good question, Dr. Samir. So there are a couple of things. There's always a learning curve for doing a good close reduction, and it will come when you do multiple attempts. Initially, you might have problems. And what we do is that we are doing this IFIX conference every year, International Fractures in Children, where our aim is to train general orthopedic surgeons to manage pediatric fractures better, where we have a 3-hour session only on supracondyle. So we discuss the pros and cons, go through all the techniques. But as you rightly pointed out, an open reduction done cleanly, absolutely there is no problem if you're not getting or struggling with a closed reduction in your practice. My only request is that somehow we have always been taught to open it posteriorly. I don't know why, because you cannot judge anything posteriorly. Secondly, you go through the fossa, the triceps get stuck, there is fibrosis there. K. Wilkins has very beautifully told us that where the proximal fragment spike is under the skin, place your incision on that, and you just disengage whatever is blocking your closed reduction. So your open reduction should be a limited anterior approach, anterolateral or anteromedial, and you'll probably find the rent in the brachialis and something which is usually the brachial artery median nerve or the radial nerve if it is anterolateral. Just disengage that, push that fragment back into its place, and then you will get your closed reduction, so that an anterior scar doesn't cause so much fibrosis and your range of motion will be definitely better. So I would just urge to shift from a posterior approach to a lateral or an anterolateral or an anteromedial approach. It's perfectly all right to do an open reduction.
Thank you, sir. I think there is
another.
There's some internet issue, I think.
Yeah, there is some internet connection issue. So I think there is one request from Dhiren sir. He has to leave to some social function, so we can take some questions later on after his talk on supracondylars.
I do have to. I'm in Ratnagiri doing a camp right now.
Yes, sir. I know.
So please excuse me also.
Yeah, sir. Dhiren sir, please, sir, go ahead, sir.
Yeah, my screen is visible, right?
Yeah, sir, please.
Yes. So basically, this is going to be one short story about a very common fracture in children. No doubt it's not that common like what Dr. Gupta or Dr. Sandeep said. But let me start with a story. This is a medical college where the postgraduate exam of the student is being conducted. And the next thing is the student who is appearing for the MS orthopedic exam is Dr. Vignesh. For him, this exam is very important because his family has spent a lot of savings after his education. And he is willing that if he's clear the MS orthopedic, then he would start earning and supporting the family. And the second thing is after 2 months, there is his weddings are planned. So this exam result is going to be very important. For his exam, there are 2 examiners. The first is Professor PM Gupta. He's from Chandigarh. And the second one is Dr. Professor Hitesh Shah, who is head of the Department of Pediatric Orthopedic at Manipal. So basically, both are very lenient examination and they are very humble examiners. So Vignesh was very confident, but he was not ready for the case. And the case which was given to him was a female 9-year-old child with this fracture. So Dr. Hitesh started with a very simple question: what is the diagnosis? And it's an easy question. And so Vignesh said that it's a Delby type 2 fracture. So the next question is, can you please tell us more about the Delby classification? So Vignesh said that the Delby classification was described by Delby in 1928, but actually this classification made popular by Colonna. And so some people call it Delby Colonna classification, and in which there are 4 types. The type 1 is a transphyseal fracture, in which the fracture takes place through the growth plate. There may be a dislocation of the physis, the proximal fragment. The type 2 Delby is a transcervical fracture. Some people call it mid-cervical fracture. Type 3 is a basal fracture or a basicervical fracture, where the fracture line is more towards the trochanter, and one of the fracture end is towards the base of the neck. And the 4th one is intertrochanteric fractures. So Dr. Gupta asked him that how does Delby classification actually help us in the management? And that's a very important practical question, because we have our various classification, but the most important thing is like they should be useful. And Vignesh said that this classification is helpful for 2 points. The first, it guides us in the management, and second, it tells us about the rate of avascular necrosis. So the most important point for everyone, and that question Dr. Gupta asked, what are the common complications of this fracture? Vignesh said that the most common complication is avascular necrosis. The second one is a non-union. Then comes the growth arrest, and the last is coxa vara. These are the common fractures over and above the other complications like infection and implant failure. So one point Vignesh said that whenever my professor sees a case of fracture neck of femur in children, he always used to tell us that complications are many and devastating. So it is better to get it right on the first go. So the next question by Dr. Gupta is, will you like to treat this such case? Because like there are many complications associated with that. So the answer of Vignesh was very practical answer. And he said that I have learned from my sir to spend a lot of time for counseling the family, because these fractures are having a lot of complications. That does not mean that we should not treat it. But whenever we take such cases, it's very important that we spend a time with family and explain them about the complications. But at the same time, we should be very careful that we don't create anxiety and unnecessary fear in their mind. The next very important question, Dr. Hitesh has a tendency to ask a question which are a broad question. And so he asked him that how this fracture is different than that of an adult. Because we see this fracture take femur very commonly in adult, but how this fracture in children is peculiar. And Vignesh has to think for some time, and then he answered that in children, there is a thick periosteum compared to that of an adult. And because of thick periosteum, the displacement is relatively less in children. The second, the blood supply in children differs at various age, and it is different than that of an adult, which has some peculiar complications like avascular necrosis. And the third is, in children, there is a growth potential from the proximal physis. And if that growth is interfered or is not taken or care of, then it may lead to a valgus or a varus deformity at the proximal femur level. So coming to the most important and the practical point, like how will you manage this fracture? So Vikas said very widely or in a broad sense that I will go for the close reduction and internal fixation. So then the next question was, which implant will you consider? And Vikas said that he will consider for 2 or 3 6.5 mm cannulated cancellous screws. The important question by Professor Gupta was, will you cross the growth plate? The Vikas was really fumbled with this question, and he said that I'm not sure. And he waited for some time, and then he said that, but before that, like Hitesh suggested, Dr. Hitesh suggested that what problem can occur if implant cross the growth plate. So Vikas said that I remember one case that during my residency, I saw almost a similar age child where the growth plates were crossed with the implant, a similar type of fracture more towards basal side, and where it was fixed with 2 cancellous screws crossing the growth plate. And that resulted into a very good reduction. The fracture united, but at 3 years, we can see that there is a short neck. So because the screws were crossing the growth plate, they stopped the growth at the physis, and that resulted into the short neck. So Vikas said that I will avoid crossing the growth plate by screws. The next question, the counter question, which is very important, that if you don't cross the growth plate, then it will be an inadequate fixation. And that inadequate fixation may lead to a further problem in the form of non-union. So Vikas said that, yeah, this is right. That is the problem with this fracture, because the proximal fragment is small and we cannot cross the growth plate, particularly when children are young. After 10 years, definitely we can cross the growth plate if required. But before 10, it's not preferred because the problem of the growth plate arrest can take place. So Professor Hitesh asked that what else can you do to increase the stability? So now Vikas understood that probably they are trying to give some hint, and he said that in addition to the screw, I can safely pass a smooth pin across the growth plate, because smooth pins are not likely to interfere with the growth, and it will increase the stability, but at the same time will not cause the growth plate arrest. So the next question was what measures you can take to avoid avascular necrosis, which is one of the common complications of this fracture. The factors responsible for avascular necrosis are many, particularly it depends on the age of the child. Those children who are more than 12, they are likely to get avascular necrosis more compared to those who are less than 12 years. Again, it depends on the fracture types that we will see how it is related with the Delby classification. More the displacement, more is the avascular necrosis. Again, it's believed that if you delay the surgery, then it increases the possibility of avascular necrosis. So it is better to carry out this between 12 to 24 hours. So as soon as possible, we should go for the fixation. The quality of reduction is also very important and important for the avascular necrosis. And fixation is again an important factor. So these are the factors. And the last one is the tamponade, the hematoma which takes place, presses on the retinacular vessels and reduce the blood supply of the proximal fragment further. So these are the factors. Delby classification has a very good correlation with the avascular necrosis rate. The type 1A, where the physis is not dislocated, has around avascular necrosis rate of in almost 1/3 of the patient. In type 1B, where the growth plate has dislocated, sorry, the physis, the proximal fragment has dislocated, as a 100% possibility of avascular necrosis. In type 2, it's almost 30%. In type 3, slightly less, that's 15 to 20%, and type 4 still further. So definitely Delby classification helps us to predict the possibility of avascular necrosis. However, there is a recent paper appeared in the Bone and Joint Journal in 2019, and that says that the Delby classification is not correlating with the avascular necrosis rate. And again, it's based on a 239 cases. So now this point is considered to be a controversial point, but still it's very important in the practice management. So when it comes to prevention of the avascular necrosis, there are few factors which are not in our control, like age of the child, the fracture type, that's a Delby classification, and the displacement. These are the factors which are not in the surgeon's hand. But what is in our hand is the timing of surgery. We try to do it as early as possible within 24 hours. The quality of reduction is very important. The fixation is also very important. And the last is a small procedure of decompressing the hematoma reduces the possibility of avascular necrosis. Again, that's a controversial point, but it takes only 5 minutes, and whatever benefit it has, it is advisable to do it. Coming to the second complications, what measures will you take to avoid known union in this fracture? The Vignesh answer was that the proper reduction of the fracture, stable fixation, particularly when the fracture is type 2, it's important that we have a proper fixation in the proximal fragment. If required, we cross the physis either with the screws, particularly when the child is more than 10 years, or with a simple non-threaded pins. We go for a lateral fixation for type 3 fractures where lateral stability is important. And if required, changing the Powell's angle and making the fracture line more horizontal. So Professor Hitesh asked, will you carry out valgus osteotomy in this case? And Vignesh answered was that I measured the Powell angle on this and it appears that it's around 30 degree. And when it's 30 degree, there is no need for valgus osteotomy in this fracture. So Professor Gupta said that we have a post-operative X-ray of this patient, and he showed this X-ray, and then he asked him, what are your comments? The Vignesh said that I should not criticize my colleague, but I think there is a poor reduction. The reduction is not proper. The screws which are used are not 6.5 screws, but they are thin screws. There are only 2 screws holding only the inferior part of the neck. There is not proper fixation, and the physes are not crossed. So the next question was, what do you expect? And Vignesh said that I'm a bit worried about the child's future. And Hitesh showed the third X-ray, and that shows that the implants are broken. So at this, I end my presentation, and I just would like to ask the panelists over here that what do you think about the Vignesh performance? Will you pass him or will you not allow him to go further? Thank you.
Thank you, sir. I think he must be passed.
Okay, yeah. Thank you, Pratik.
He is
Let's have the
given his exam actually.
Yeah.
Dhiren sir, it was nice presentation. Actually, the way of presentation is really good, and I think it was nice, quite new
yes,
for almost everyone,
much.
I think.
Yeah.
Anybody having any question to Dhiren sir? Harmesh
Yes,
sir?
sir. Yes, sir.
Very good presentation, sir. One question, depending on age of the child, does the implant selection change? There used to be, when I used to be in PG, there's Knowl pins, Moores pins, they were very confusing. So now it is standard only to use screws, or there is a special pin still used for a particular age?
Yes, that's a very important question, and which I have not emphasized or clarified in this presentation. I really appreciate that you asked this question, because yes, implant selection depends on the age of the child. When child is less than 5, we need to use for what you suggested, the novel spine or some or the other options which are thinner in size. As the child size or the age increases beyond 5 and towards 10, we can go for a bigger implant like cannulated canceller screw. But yes, for a child who is less than 5, we need to use for a thinner implant. And in that case, the important thing is like, because implants are not strong enough, we have to supplement with the hip spica also. So that's the additional thing which we need to use in children.
Just to continue the same, if the child is small and for some reason holes are not available, can we just use thick K wires and bend them and leave them inside and then remove them later on?
Yes, we have done that for a child who is between 2 to 3. We have done that. Yeah, we have used the thick K wires, bend it, and then use the spica. Yes.
And for an older child, cannulated screws versus DHS. So which one is preferred? And
okay, so again, yeah, that's a very good question. Again, not discussed in the presentation. Particularly type 3 and 4, we can use either a mini DHS, or now Synthes has a new plate of 130-degree angle blade plate with a locking plate. That implant also we can use. Some of my colleagues have used even the plate of the proximal humerus also for the fracture fixation in a neck in children. So these are the options which we can use for type 3 or type 4 fractures.
right, sir. Thank you. Thank you, sir.
Thank you.
Thank you, sir. Are there any other questions?
One question, Dr. Ravi.
Yes, sir. Lalit, sir, please.
Thanks, Dr. Ganjwala. Excellent presentation and a great idea of how to bring out the same facts. Can you tell us your preferred way of reduction in an displaced fracture? Is it in flexion or do you prefer reduction in extension?
Okay, a very good question. And like we follow almost the same technique which we use in the adult. The only plus point in children is, as I said, that because there is a thick periosteum, the amount of displacement is not that big as we see in adult. And that's a beneficial point because the reduction maneuver does not become that important. But yes, I carry out reduction in extension. Usually a gentle traction and internal rotation is sufficient. But if that is not adequate, then we need to use joysticking to get the reduction. And in a very small number of cases, we may have to resort to open reduction. Sir, you are mute.
Lalit, sir, please unmute yourself.
Thank you, sir. Thank you so much.
Yeah, thank you.
Thank you, Dhiren, sir. It was really a nice presentation.
Yes.
So, are there any other questions from the panel? Any other? Okay. Sir, Dhiren, sir, my question is just in case of the late presenters, those who are presenting on second or third day or fourth day sometimes in our country. So, what's your take on those patients about the reduction technique, or you go for opening it, or what's your approach actually in those cases?
Okay, as I suggested, like the reduction is very important thing. So we start with the close technique. If that is successful, it's fine. If not, then we add on the joysticking to maneuver the proximal fragment. And if we are not happy with the reduction, then we need to go for the open reduction. So whether it's a close or open or a joystick, that's not important. But the important thing is like the fracture reduction should be good, because that's where the reduction in the complication rate can be achieved.
Thank you, sir. And sir, about passing the threaded portion beyond the basically fractures,
growth plate,
especially in earlier grades like subcapital or those fractures, or even transcervical to the above to that. So what's your take? You always supplement with the smooth pins or just pass the?
Okay, if child is less than 10, then it is better to avoid crossing the physis and then add on with the crossing with the smooth pins or wires. If it is more than 10, the age of the child is more than 10, then I think that if we cross the physis, yes, there will be some shortening of the neck, the trochanter overriding. That's not going to create that big a problem. But on the other hand, if we don't have a good fixation, then definitely it leads to the more devastating complication like non-union, which is very difficult to salvage. So in that case, we accept some problems in the form of a short neck or the trochanter overriding so that we can reduce the complication rate.
Yeah, because our primary aim is to reduce it properly and to fix it properly.
Exactly. That's the primary thing.
Other things came later on.
Exactly.
Yeah. Thank you, sir. Thank you, sir.
Thank you. Thank you.
Thank you so much, sir, for an excellent presentation. So
thank you, Ravi, for the opportunity.
Forward, thanks. It's our pleasure to have you on this platform, sir. So now moving forward, our next presenter will be Dr. Prateek Behra. He will be speaking on fractures around the knee. Dr. Prateek, please share your slide.
Yes, I'm sharing my screen now. So is it visible for everyone?
Yeah, please go ahead, Dr. Prateek.
So after an interesting presentation by Dr. Dhiren, let us go around and talk something about fractures around the knee. So let us first concentrate on what is the difference between pediatric and adult skeleton and why is it important. So if we, like Dr. Dhiren just now told about the thick and strong periosteum, this is actually an important factor in deciding the amount of displacement. Additionally, the porous and flexible bones of children limit the amount of comminution and propagation as compared to an adult's bone. So the fracture pattern which we usually see in adults is not commonly seen in children. Additionally, the presence of physis, the growth plate, is another important deciding factor. The inherently weak zone of hypertrophy and the presence of this physis at times decides how you take your decision for management. Additionally, the ligaments and tendons which are attached to the cartilaginous structures in young children are relatively stronger. So the injury pattern which we see is different. The same forces which can produce a ligamentous injury in an adult actually tend to produce a cartilaginous or bony injury in children. Additionally, an inadequate or improper management of fracture involving the physis can result in angular deformity or limb length discrepancy or both. Then comes the question, the special consideration for adolescents. These are those group of individuals who is neither a child nor an adult. The physis has actually started to fuse in these patients, in these individuals, but the fusion of physis is not simultaneous. What this means is that there are areas which have actually started to fuse, but others are cartilaginous, and the injury propagation, injury pattern will be different. So while discussing about the injuries around the knee, we will be touching something upon the distal femur, about the tibial spine, patella, some portions of the proximal tibia. And in general, what is common in almost every pattern of, in case of knee fractures, the mechanism of injury is usually either a direct blow to the knee or a fall from height, road traffic accident, especially the high velocity ones. Now, if you look around, there are many children who are underage for driving a two-wheeler, but they will be riding the bikes even better or even faster than the adults. Additionally, sporting activities which involve contact sports, if you go ahead and see, the Pro Kabaddi League is again going to come back, and people are now interested in sporting activities from the younger, considering the importance being given to the Olympics and all other activities. So these are the factors which can actually lead to further fractures around the knee. And usual presentation to clinic for almost all fracture is a common presentation of pain, swelling, deformity, and inability to bear weight. When we examine, usually there is tenderness and often a knee effusion resulting from an hemarthrosis. The examination in patients with who have sustained an injury around the knee, special attention must be given to three important structures which are quite near to the knee, especially on the posterior aspect. It is primarily the femoral and the popliteal vessel, sciatic and its terminal branches. Once this is done, we have to take a call for management. We have to resuscitate the child. Once the patient is fine, we go ahead and perform our imaging studies. While taking the patient for imaging studies, it is a good idea to splint the fracture to limit any further damage and to relieve the child from the pain in which he or she might be. We have to obtain radiographs. The bread and butter radiographs are the AP and lateral. The lateral should preferably be taken in 30 degrees of knee flexion, which might not always be possible given the circumstances of the injury around the knee. But yes, if it is possible, 30 degrees is a better view. Oblique views for suspected physeal injury, we will look at the importance later on in this presentation. And at times, merchant view for suspected patellar fracture or dislocation can also be ordered. In addition to these bread and butter imaging study, the others like MRI, CT, and ultrasound, they do have their role. They must not, however, be ordered in all the patients, and they are to be used selectively, especially when this is going to affect the management decision. Let us talk something based on a case-by-case type of presentation to discuss something about the distal femoral metaphyseal fractures. These can be considered as the equivalents of supracondylar humerus fractures in case of upper limb. So these are the supracondylar femur fractures. These are 12% of all femur fractures. And if you look at the image on the right, you see that the injury pattern is such that the gastrocnemius muscle is pulling the distal fragment towards it. So the distal fragment is in flexion. And this actually can result in, this type of pattern, fracture pattern can result in injury to the posterior neurovascular bundle, like we already discussed. Additionally, whenever we are evaluating any AP or lateral radiograph, we have to see and rule out whether that fracture line, which we are believing to be a simple metaphyseal fracture, is actually some sort of a physeal fracture. We will see an example later. So once we have done this, we have to look ahead and go for management. Like in any other fracture, the common pattern is we have to obtain an acceptable reduction, which may or may not be anatomical, but it has to be acceptable, and then we have to maintain that reduction. Initially, we have to salvage the limb in life, followed by our further management. So the non-operative management is primarily with the help of a cast. One can directly reduce a reducible fracture or even a minimally displaced fracture and then apply a cast, which can be a high groin to toe cast, or if required, a single leg hip spica cast. At times, initial traction followed by a cast is more beneficial. A 90-90 traction, in which one of the pins goes into the distal fragment and the other one into the proximal tibia, can be used to reduce the fracture. And once the fracture becomes sticky, somewhere between 2 to 3 weeks, we can convert it into a cast. Operative treatment does have its role, and these operative treatment, a surgeon must never be shy of using them. And when do you use? Whenever a relatively displaced fracture, which is fails to stay reduced in a cast. We have displaced fracture is there, we have reduced, but the reduction fails. Or in case there is an open injury or vascular injury, which is going to require vascular surgery, we always go ahead with an open reduction in that scenario. For relatively those fractures which can be easily reduced, we can go ahead, do a close reduction and simply pin, followed by application of a cast. External fixators, either monolateral type or lateral type, they do have their role, and they are useful in open cases, those with polytrauma and even floating knee. Submuscular plating can also be used. Let us look at this case, which I initially started with this segment of presentation. So this is an 8-year-old child who had actually fallen down from a tree, and the injury was a direct blow to one of the big roots. It was a large tree from which he was playing, and the child actually had fallen down. So the management which was done was, under anesthesia, traction was applied. We were able to achieve linear reduction. However, the proximal fragment was not completely getting reduced. So a joystick method was used. A percutaneous hand screw was passed in, and it was used for levering out the fracture. After that, we put in 2 crossed pins. Finally, at the end of 6 months, we were able to achieve a good reduction. The child was relatively pain-free with no issues. Let us look at another case. This is a 15-year-old boy. Like I told, this is that adolescent age group population where the individual is not an adult nor a child. So he was riding a bike in high speed, fell down. He presented to us with this injury. On the radiograph, we can make out a medial side comminuted supracondylar type of fracture in the metaphyseal area. But if we look at this area closely, what we find is the fracture line is actually progressing up to the physis. Additionally, on the medial side, one can make out that the physis has started to close on the medial side. So how do you classify, how do you manage these things? Let us then look at first the distal femoral physeal fractures. This is classically classified by the Salter-Harris classification, which everyone knows. It starts from type 1, 2, 3, 4, and 5. Type 1, relatively good prognosis. The fracture is along the plane of the physis. Type 2, the typical Thurston-Holland sign, which is diagnostic of this fracture. It is a metaphyseal beak. The type 3, the fracture line is exiting, taking a piece of epiphysis with it. In type 4, there is both a metaphyseal and epiphyseal peak. In type 5, there is crushing of the physis. And if we look at all the physeal injuries, about 5.5% are accounted by these distal femoral physeal injuries. These are important because the distal femoral physis is the chief contributor of an individual's growth. The height is contributed the maximum by the distal femoral physis. And irrespective of the type of fracture, mechanism of fracture, the type of reduction, and whether how much early or late the reduction was done, there is high probability of growth disturbance in these type of fracture. It is along with this, whenever we are getting a distal femoral, like we already discussed, we have to have an assessment of any associated vascular injury, and we have to perform a subsequent management of that. Once we have classified, we have managed the patient initially, then we have to decide whether we are going to manage the child either non-operatively or we are going to intervene. So non-operative management in the form of a long leg cast or a single hip spica can be used especially in relatively undisplaced fractures if it is type 1 or 2 Salter-Harris. Operative management in the form of close reduction and percutaneous pinning is used and preferred for displaced type 1 and type 2 fractures. Here the pins are smooth and they can cross the physis. The percutaneous pin fixation is preferred for undisplaced type 3 and 4 fracture. It is better not to manage these because there is high probability of displacement. Open reduction and fixation can be used for displaced type 3 and 4. Type 5 fracture, there is no clear-cut answer whether they should be operated or not. Most of the surgeons, they avoid operating on this because the physis is believed to have already been terminally injured. So if we try to summarize, in case of a type operative fixation, if we are going to do, then for Salter-Harris type 1, smooth pinning. For Salter-Harris type 2, we have to reduce the Thurston-Holland sign and reduce the metaphyseal piece to the metaphyseal piece. Similarly, for type 3, we have to reduce the epiphyseal piece to the rest of the epiphysis. And the type 4, we have to reduce metaphysis to metaphysis and epiphysis to epiphysis. Let us look at another child. So this was a girl who was 4 years old and she fell down while she was riding pillion from the scooter. She sustained a supracondylar type of fracture, is it so? Or there is a physeal injury. This X-ray is actually, I must acknowledge, not very clear, but there is also an additional supracondylar femur fracture. So close reduction and percutaneous pinning was done for type 2 supracondylar fracture. We will see why this is type 2. So once the cast was removed, we can make out that there is a Thurston-Holland fragment, and this is the rest of the epiphysis. So this was a type 2 fracture, which was managed closed with percutaneous pinning. This was the image after 3 months, after which the pins were removed. However, the child developed an angular deformity, and additionally, she developed a growth arrest. So what are the factors which contributed to this? Like we have previously discussed, the severity of injury is the chief contributor in this case. It was a severe injury. The distal fragment was almost completely rotated, and even after a reasonable close reduction, it developed a physeal arrest. Let us look at another case. So this was a young child, developed a two-wheeler accident, and at that time there was a long spiral shaft of the femur fracture, and additionally a type 3 supracondylar humerus fracture. So this was managed surgically. Because of the long spiral fracture, submuscular plating initial attempt failed. So this was operated by the conventional mean, and the Salter Harris type 3 fracture was then taken care of by a single screw. Now let us go and discuss the case which actually started this discussion of ICL injury. So this is a type 2 Salter Harris type of fracture in an adolescent child. So what we did was, under an image intensifier, when we applied a valgus stress, the fracture alignment actually improved. We were now able to make out clearly the amount of comminution and the extent of fracture line into the physis. So after this, percutaneously 2 screws were passed on. Then came the decision whether to manage this in a cast or whether to go ahead and add some other fixation. So given that the child was 15 years old and on the medial side the physis had actually started to close, we decided to let the child mobilize early, and we put in a plate, taking care that the screws were not crossing the physis. So there were screws in the epiphysis, there were screws in the metaphysis, but no screws through the physis. Now let us look at another condition, the Hofa fracture. So these are the coronal plane fractures like we all know. And contrary to what one might think, these are not these can also be seen in children. So let us look at this child. So she was a girl who came to us after 4 weeks of initial treatment at another hospital, where she had presented after the auto rickshaw in which she was traveling turned over. So the doctor there, they identified it as a soft tissue injury, applied a slab and kept it for a period of 4 weeks. Once the slab was removed, she was still in acute pain. When she came after removal of the slab, we could make out that there was something inside the joint, which is very clearly seen like a semi-lunar type of structure. We went ahead and obtained a CT. The CT scan showed that the lateral side posterior femoral condyle, the fracture was there, and this was actually lying inside the joint, knee joint, in between the femoral and the tibial condyle, and preventing movement. And whenever she attempted movement, she had severe pain. So we went ahead through a medial parapatellar approach, and we fixed it with two headless screws. The possible complications, like we discussed, are angular deformity, limb length discrepancy, or both, and rest of the complications are as associated and are as expected for any individual with an injury around any joint. Let us discuss something about the patella fracture. As we all know, patella is the largest sesamoid bone, and it plays a role in the quadriceps mechanism. As it has attachments of very strong tendons both proximally and distally, there is chance of it getting injured is high. Additionally, there is no clearly visible patella at birth because it is completely cartilaginous. In ossification centers, they appear around 3 to 5 years of age. The classical transverse or comminuted fractures, as in adults, are not seen in children. They are seen in adolescents. The patella fracture accounts for around 1% of all pediatric fractures. The transverse or the comminuted type of patella fracture, they are best appreciated on lateral radiographs, and if undisplaced, like that what we do for adults, we can manage with cylinder cast or knee immobilizer with the knee extended for the undisplaced one. And if it is displaced, then we can manage with the similar to an adult using K-wire and tension band principle or screws. Additionally, the torn retinaculum must be repaired and it must be a part of surgery. Beware of this type of fracture. This is called as a sleeve fracture. Why sleeve? Because the sleeve of periosteum and the cartilage is pulled off from the rest of the patella. The inferior pole, which was the originally described pattern of sleeve fracture, is the commonest one, but superior pole injury can also be there. Why does it happen? It happens because of a powerful contraction of the quadriceps whenever a child is attempting to jump or run, or while the child is attempting to kick. How do you identify? So whenever we are obtaining an X-ray and we find that there is evidence of patella alta, the patella is appearing much more higher, the location is at much higher level, and additionally we have a small fleck of bone on either pole. Here in this image, we are able to appreciate this on the inferior pole. then it is suggestive that something is wrong, not everything is right. And then in that scenario, and it should ring in a bell in our mind that it might be a sleeve fracture. Ultrasound and MRI are often helpful to clarify the doubts, and an open reduction followed by suture repair of this torn periosteum and the cartilage is the way to go. Now, one must be aware of these two types of fractures. One is a bipartite patella, which is, and another one is a Sinding-Larsen-Johansson lesion. Both of these might be confused by the unaware person with a fracture. But if you look, the patterns are quite different. The bipartite patella commonly is located in the superolateral pole. The what appears as fracture ends are actually smooth, indicating that they are not real fractures. Same is the scenario with Sinding-Larsen-Johansson lesion, and it can be considered analogous to your typical Auschwitz-Latter disease of the proximal tibial tubercle. Let us discuss something about Tbl spine or the tibial eminence fracture. The anterior tibial spine provides attachment to the ACL. This area is primarily cartilaginous till the time it is fully ossified, and which tends to take place between 8 to 14 years of age. Assessment of the tensile strength of the ACL and the tibial spine, once done, we find that the ligament is much more stronger than the tibial spine. The tibial spine is cartilaginous, right? So whenever this knee in between the age of 18 to 14 years is subjected to an hyperextension of valgus load, when the leg is in position of external rotation, then the ACL is pulled. The ACL, instead of getting torn, pulls away the tibial spine. The mechanism which produces ACL rupture in adults can produce an tibial spine avulsion in children. Mayer and McKeever's classification is what is universally used. It is relatively simple. It defines it into three types, 1, 2, and 3, depending on the extent of displacement and the amount of intact posterior hinge. In cases when there is no intact posterior hinge, it is an indication for surgery. Additionally, there has been description of a comminuted pattern, which is labeled as Mayer-McKeever type 4. So how do you identify? Again, the bread and butter investigation is AP and lateral radiograph, MRI and CT whenever a clear decision cannot be made. What will happen if we don't treat it? Well, the flexion deformity is going to persist. The child will land up with a flexed knee. So the treatment can be non-operative or it can be operative. The non-operative is treated, it is offered universally for type 1 Mayer-McKeever's classification type, and in type 2 if it is reducible with a knee extension. How do you treat? We can apply a cast. Usually a cylinder cast or a long leg cast can be applied. The position is debatable. There are few people who use the cast in full extension. Others, they advocate 10 to 20 degree of knee flexion. Overall, the final results have been shown to be similar. Operative treatment is indicated for the type 2 type which fails reduction, and in all type 3 and type 4. How do you do it? Well, it can be performed either by open surgery or by arthroscopic means if there is training for arthroscopic repairing adolescents. Screw fixation can be used. One can use suture fixation over a suture disc or even on a bony bridge. So let us look at a case example. So this child, he was 15 years of age when he came after a period of 3 weeks. So he had actually fallen down from a bike and was initially managed in a knee immobilizer. When he came to us, the child was unable to achieve full extension, and we can appreciate the presence of an anterior tibial spine avulsion. We obtained a maximum possible extension film. The extreme right one is the one, and we find out that the child was actually not able to fully extend the knee. The child had also come with MRI done at another center, in which one can appreciate the avulsed ACL piece lying in between and in contact with the femoral condyle. So we went ahead, opened the knee, went through the medial parapatellar approach. We found out that the avulsed fragment was there protruding very anteriorly, and it has actually started to mark its impression on the femoral condyle cartilage. So what we did was we cleared up the debris. We used a ethibond at the junction of the ACL. This is the ACL and the tibial spine. We pulled it down and then put 2 screws into it. So With the screw fixation, this was done only just recently, so I don't have long-term follow-up X-rays, but we were able to obtain, you can see the full knee extension with it, which was verified on table. So the possible complications for these type of TBL avulsion fracture is persistence of laxity even after surgery, because the amount of tension which needs to be provided to the ACL cannot be judged. If it is a very fresh case, you can actually achieve a perfect anatomical alignment. However, in late presenting cases, there is usually fibrosis, there is usually some amount of adhesion, and while you are trying to reduce, most of the time perfect anatomical reduction is not there. Joint fibrosis is again a big issue, because even after fixation, we tend to protect the repair, we tend to protect the fixation, and the mobilization is often delayed. Non-union and malunion are again associated complications. Let us discuss the last aspect, the proximal tibial physeal fractures. These are very uncommon. These are seen accounting for only 2% of physeal injuries, and it has been proposed that the proximal tibial physis is actually a privileged type of physis because it has got guards all around it. There is fibula on the lateral side, the overhanging tibial tubercle anteriorly, and there is a very wide insertion of semimembranous posteromedially. However, injury can happen, and these injuries happen when there is an hyperextension or abduction force is applied onto a knee which is fixed onto the ground. Now, if we look at here, the distal fragment, it develops as a sharp spike, and it can again displace posteriorly to impinge on the important neurovascular structures. So how do you proceed? We use the Salter-Harris classification similar to that used for the distal femur fracture for deciding on the management. In addition, we have to identify the direction where the displacement has happened, because that will aid in identifying what force must be applied to achieve a closed reduction, and also to achieve an open reduction if required. Like Dr. Sandeep told very lucidly, that we have to approach that side which is actually causing impingement. So we must try to avoid those areas where the periosteum is intact. So the principles of management of this is based on the Salter-Harris type. Undisplaced type 1 and 2 can be managed in a long leg cast, but as Dr. Vikas emphasized, reduction must be reassessed every week till about 2 to 3 weeks. For displaced for Salter-Harris 1 and type 2 and undisplaced 3 and 4, close reduction and percutaneous pinning with smooth pin is the way to go. ORIF must be used without any hesitation as and when needed for achieving reduction and stable fixation. The fixation can be with the help of screws, plates, and K-wires as demanded by situation. With this regard, let us discuss this case. This is again that transition zone, the adolescent period, when the child came to us with a type 4 type 4 Salter-Harris fracture. We can find that there is a big chunk on the medial side which is displaced distally. So we started the case by attempting to reduce it closed, and percutaneously we passed in a K-wire to push it up. Finally, with the help of a K-wire, we used it as a joystick and used reduction clamps to achieve the reduction. We passed in a screw along the epiphysis, and that provisional reduction was held with K-wires. However, after removal of the K-wire and the joystick, we found that the reduction was not stable because the metaphyseal fragment was quite large. So again, deciding to gain more stability than salvaging the physis for whatever limited growth was there, we added onto a plate. So what are the possible complications? Same as that of the distal femur, growth arrest, angular deformity, joint stiffness. It is associated, it is often found. The last case, one of the patients who was operated by me, the patient presented with an angular deformity along with a limb length discrepancy. He had actually sustained a physeal injury 2 years back, and as it was the initial pre-COVID, just the first wave of COVID, he was managed non-operatively in his village itself. However, when he came to us, he presented with knee instability. He was saying his knee is trying to go anteriorly. And when we look at the X-ray actually, what we find is that there is a reversal of the tibial slope and that there is a malunited proximal tibial physeal fracture. So we formulated a plan to address the deformity, which was actually in an oblique plane, not a pure coronal plane or sagittal plane deformity. There was a reversed slope of the tibia and limb length discrepancy. So the plan was to utilize the Elizaro device. We planned a proximal corticotomy, angular deformity correction in the first step, because we are the Ayushman people here, so we don't have the luxury of using hexapods, and frame modification to regain length. So this was the X-ray which was obtained in the immediate post-op period. The deformity is almost same as it was there, no correction, nothing, just applied the frame, and this was after 3 months. So this child is planned for removal of the frame in the month of June. This was a recent X-ray only. So now the child is comfortable walking around. In order to summarize, an orthopedic surgeon must be vigilant while assessing a child or adolescent individual with an injury around the knee. The features which we are expecting that there might be there to have a vascular injury or neurological injury, they might not be actually evident on initial radiographs. There is a high probability that injury has happened and the fracture is reduced. But we have to suspect, we have to identify, we have to take the possibility of those life-threatening injuries, and the management has to start with counseling and information of the parents about the likelihood of the different sequelae. Finally, the surgeon must use whatever available techniques are there to obtain an acceptable reduction and then maintain the same by using cast, pins, plates, screws. All the devices are there to be used. Thank you for your attention.
Thank you, Dr. Prateek. Am I audible?
Yes, sir. Please go ahead.
Thank you. Are there any questions for Dr. Prateek? I think we are already late.
Yes.
We have already crossed a lot of time, actually.
Can we ask one question, Ravi?
Yeah, please, sir.
Prateek, nice
sir.
presentation. I just wanted to know for your Tbl spine fracture, which you opened and fixed.
Yes, sir.
In this age group, can we have the arthroscopic fixation also?
Yes, sir. Arthroscopy is a definite option. However, the child was quite late in presenting, and I was apprehensive looking at the X-ray and the MR whether arthroscopy will be able to bring it back. So actually, we even struggled in the open also because it had already started to adhere onto the bone in a malaligned position.
Okay.
Thank you, Dr. Prateek. Yeah, Harmesh,
Yes,
sir,
sir.
please.
Just a small question, Dr. Prateek.
Yes, sir.
One patient of 15-year-old supracondylar femur, you showed,
Yes, sir.
where we put in a plate,
Yes, sir.
where you said we will be passing screws distal to the and proximal to the physis.
Yes, sir.
So, in case we are using only screws, then probably it's fine that you have not crossed the physis. But if it's plate, so
Yes,
the
sir.
distance between the proximal and the distal screws has been fixed by the plate.
Yes, sir.
So even if you have not crossed the physis, I don't think it will be able to grow.
Sir, actually,
What are you
the plate
thought?
was removed later on. After 9 months or so, when we had the union there, we removed the plate. This was 15 years. So plate removal actually allowed probably some further growth. The patient has not come to me in the past 3 years, but yes, the plate was removed.
So I wanted to clarify, till the time plate is there, it will
Yes,
not
sir.
allow the
Exactly, sir. Till the
because
time
it
plate is there,
equal
the
to-
growth is going to be restricted. But in this scenario, there was a good amount of medial comminution. So in order to supplement that fixation, we added on the plate.
There's no talk about that. I was just clarifying about
Yes, sir.
the
No,
growth
that
rate.
definitely, sir.
part.
There was no growth
Like-
for period of the time the plate was there.
Prateek, regarding the same patient
Yes,
with
sir.
medial comminution,
Yes, sir.
biomechanically, should you go for the medial plate buttressing?
Sir, that is an
Instead of
excellent
putting the-
question. But actually, in this scenario, that would have added on to even much more dissection. And the idea was to add one device laterally to prevent it from further collapsing. So I think lateral plate, the current recent ones which are available, they are sturdy enough. The 4.5 plate we use. And actually, him being a 15-year-old was an advantage for us because he was almost like an adult.
This combination was actually less than what they suggest as 2 centimeters. But if it is more combination, then I
Yes.
think we have to prefer a medial
Yes,
plate.
in that scenario, we can supplement one more plate, sir.
Thanks, Dr. Prateek. Are there
Thank
any
you.
other questions? Okay. So,
No, I would like to thank Dr. Ravi and the entire DOA team for organizing this. Though it is quite late, but we had very interesting 3 presentations, especially from Dr.
actually,
Ganjwala. It was very nice,
great.
actually.
It were great presentations actually.
Yes.
So I have collected few of the cases actually, just those cases that were remained out
Okay.
of the femoral neck fractures, and those I think we are quite late. Atul sir, what do you say?
If the participants are okay, another 15 minutes.
If people are okay, then I will be very quick. Lalit sir?
Yeah, sure. I think we'd like to look at the case.
We like to have it.
Yeah.
Okay, thank you, sir. So I will be very quick and I want the participation of our panelists all over. So my first case is a 10-year-old boy. He sustained injury in his right thigh due to fall from stairs at home, primarily managed with above knee slab elsewhere outside, and presented to us after 2 days of injury. This was his pre-operative images. So he sustained a fracture femur shaft diaphysis region. So what's the take of audience or panelists?
Ravi, how old is the child?
Sir,
4 years? Ravi, how old is the child?
Sir, 10-year-old.
So I would go for Enders nailing in this case.
Okay.
This is a clear-cut case for Enders nailing, I guess.
Enders or tens?
Tens nails. I mean tens, yes.
No, the tens, it will
Yes.
be for tens nail,
Yeah. So exactly same I did. And these were the immediate post-operative images. So we did the tens nailing, and these were the subsequent follow-up images. Fracture healed well, and this was at the time of tens removal. And this was the follow-up image after the implant removal. So the take-home message is that for diaphyseal fractures, if the weight is below 50 around and child is not that much obese and the fracture is stable enough, so in around 8 or 9 years or 10 years, even in 11, 12 years, tens nail works well. So is there any other take of another faculties or?
Ravi,
Yeah, sir.
I feel they can be plated also very easily, and that gives a very good sense of stability at the time of surgery itself. And
Yes, sir. We can do the submuscular plating, but fracture was stable enough. That's why I have chosen the tens nail. And
I'm not
Dr.
saying
Hamesh,
tens
it's
nail is not
plating.
good. I'm just
Dr. Hamesh, you're
saying
absolutely
it is an
right.
alternative.
Yes, absolutely. It's an alternative. It's about decreasing the morbidity, and keeping it minimally invasive. That's about it.
yeah.
Sir, actually, if I may, sir, actually, stable fracture patterns are very well
Yes.
managed with either of them. For relatively unstable ones, submuscular plating is probably preferred.
Is
But
preferred.
if it is stable fracture pattern, it is easier. Just put in 2 nails; they can be removed easily also.
Because
Yeah,
if the
it's-
fracture is stable enough, there is no such instability, then tens nail works well and it's a minimal invasive procedures. So
No,
I
it is
think,
well accepted mode of treatment. What I'm saying is, in children, especially the smaller children, so the bone thickness is much less than the muscle and the fat. So it is not easy.
Those issues are in early age groups, like 3 or 4 years. In those, we don't do tens nails. We do the hip spica, and that works well. We usually do
5 years of age.
Yeah,
You
sir.
don't
We usually do tens nail above more than 5 years or 6 years.
more than
like
5 years, and it is a transverse fracture, so
Yes,
it is
sir,
best indication for the tens nails.
It was a stable enough fracture.
Yeah, Ravi, I think you say length stable fracture, and the implant of choice is ASIN. There is elastic intermedullary nailing.
Yeah, sir. Yes.
And doing a plating is actually violating the fracture hematoma, and you need another surgery, major surgery to remove the plates.
Definitely, sir. Definitely.
The choice, there should not be any other choice unless there are some contraindications.
Yeah, definitely. Thank you. So I am moving to next case. My second case was 7-year-old girl. He had a cystic lesion in the metadiaphyseal region and diagnosed initially as a ABC. So we treated her with intralesional sclerosing agent. And but unfortunately, after 2 months of single dose, she had a fall at home during walking and sustained fracture at the site of lesion. This was her preoperative images at the time we did the sclerosing agent application, and this was at the time of fracture. So she sustained fracture at the lesion. It was a pathological fracture. So what could be the management? I just open to the panel.
Is it
Vikas, sir?
UBC?
It was ABC, sir. Aneurysmal bone cyst. Yeah.
Biopsy proven?
Cast, sir?
Biopsy proven?
Yeah, sir. I did the aspiration at the time of when we have introduced the sclerosing agent. Then it was typical ABC.
Actually, the site is very atypical.
Yeah, site is quite above at the mainly it is diphyseal as such. It's a.
I think in this scenario, you can go ahead and perform an extensive curettage, harvest graft from the iliac crest, fill it up, and apply an pediatric LRS. Let the child walk around on this LRS itself, and the graft will fill up the area.
Yep.
And if it is ABC, it should heal well.
Yeah, okay, but we usually don't do grafting in ABCs. What I did, we did the tense nail, and just because of the tense nail, we did the curopsy just by rotating the tense around the lesion. So our job was done, and these were his final follow-up image after the implant removal. The fracture healed well, and even you can observe that the cystic lesion has also healed well, because we have done the curopsy at the time of fracture fixation with the tense. So this was at the final follow-up image a few months back. So any take?
Good outcome. Actually, this we normally do in a humerus.
Okay.
It stabilizes the fracture as well as it helps to drain the fluid also.
Yeah. We usually don't use the grafts. Nowadays, we use sclerosing agents, and in 3 or 4 doses, the ABC heals well, is sclerosed well.
The only thing is you have to immobilize it for long, probably with this technique.
Sir, for sclerosing use, one precondition is that there should be no breach in anywhere in the cortex.
Yeah, definitely. So initially when we had used the sclerosing agent, there was no breach. But once it has fractured, we have not used the sclerosing agent. We have just done the curopsy with the help of tense nail end, and we just curopsed the whole ABC area, and thus we did the tense nailing. Nothing more than that.
Good outcome.
So my next case will be 12-year-old boy. He sustained injury in his right shoulder due to fall from two-wheeler. He presented to us after 4 days of injury, managed initially with an arm pouch and analgesics. So initially, some of the surgeons did this X-rays, and they have advised that there is no such injury, and it will heal in shoulder immobilizer or just an arm pouch. So what's the take of panelists?
Like posterior dislocation.
Actually, the
Ravi,
views are not appropriate.
Ravi, by the look of this X-ray what you are presenting, I think looks very well for a conservative management, frankly. Unless I'll suggest something, I'll get a CT scan done. पर इस पे तो मुझे conservative लग रहा है.
So moving forward, sir, what I did the true AP view. This is not true AP view. Actually, it's a rotated or internal rotation views or some sort of like that. And another one is the scapular Y view. So what I did the true AP view, and this was the presentation at the time of that. So there was total physeal separation, epiphyseal and metaphyseal. There is a discontinuity. You can appreciate it was significant. So now what should be the management?
It is almost like a Salter type 1.
Yeah. So you need to reduce it and do a pinning. I guess this would be the thing to do.
Yeah, exactly.
Close.
Exactly same I did. I have used the pin, smooth pin in the epiphysis just to reduce the fracture, just to reduce the displacement. And once it is replaced in its position, then I had pinned from the lower side, and I did the two. These are the intraoperative C-arm images, and these were the immediate post-op images. This was the final image at the time of implant removal. So, Vikas sir, any other take on?
No. This is
Nicely done. Ravi, nicely done.
Nicely done.
Thank you, sir. So, my next case is the 13-year-old boy. He sustained injury to his left wrist due to fall while riding a bicycle. He presented to us with pain, swelling, and deformity around the wrist. So, when we did the X-ray, then he has sustained the distal radius and distal ulnar fracture at the metaphyseal region. So, what should be the management? Any panelist?
It's 14.
Yes, sir. 13-year-old boy.
I think give an attempt for close reduction first.
Exactly. An attempt of close reduction can be taken.
Trial of close reduction is always.
And close reduction and casting, or sir, close reduction with pinning?
Now you can judge the stability on if you are using it under image intensifier, you can judge the stability. If it feels unstable, then adding pins should actually be a good idea.
Okay.
Yeah, keep a low threshold for pinning.
Yeah, actually the same thing I did. Just intraoperatively, we find that the fracture was unstable enough because there was in the metaphyseal region, the fracture was in both the radius and the ulna. And putting pin is sometimes quite difficult in this sort of metaphyseal regions, just putting cross pinning like that. So we did the pinning, and these were the immediate post-op images. And these were the subsequent follow-up image. So this was the image at the time of K-wire removal. I have removed the wire at around 6 weeks. So any other take on from any panelist or different sort of management?
Dr. Ravi, I think you could have added a pin starting just lateral to the listed tubercle posteriorly and directed anteriorly to engage the anterior cortex. So one from the styloid, one from posterior near the listed tubercle. That will give you a wide enough coverage and almost a cross pinning type of situation.
Yeah, that could have been done, sir. Definitely. Point taken. Yeah.
And Dr. Ravi, unless we like you say it was unstable, normally such cases are managed very well by the close reduction and plaster cast.
Yeah, actually, I was having low threshold for this pinning. Actually, it was unstable. Age was on the higher side, so that's why I've opted for pinning this.
No harm done.
Nice. To be on the safer side. So, moving on to the next case, the 10-year-old boy sustained injury to his left forearm at a water park. He presented to us with pain, swelling, and deformity in the forearm. This was his pre-operative image. He sustained the fracture of both bone. The radius fracture was at the proximal and the ulnar fracture at just the mid-diaphyseal region. So, what should be the management? Any panelists?
Ravi, since the child is 10-year-old, like you say,
yes,
the fracture is very proximal, and you already put a plaster or something, and
it was a slab.
It was slab. So I think I would keep keep in mind that I would may like to put a tense nail, fix it, and be sure of a good interosseous space and finish it off like that.
Samir sir, same thing I did. I did the tense nailing for both the fractures, radius as well as ulna. And this was the final follow-up image after the implant removal. Fracture healed well. Alignment was well maintained.
Yeah, Ravi, well done.
Well done.
Now you should choose a distal ulnar entry point, which makes alignment much better. So
okay.
Distal ulnar alignment, you can use both the nails, sometimes with a joystick, which can help in reduction.
Okay, thank you, sir. Thank you, sir. So my next case is a 12-year-old boy. He sustained injury to his left shoulder by playing a football. He presented to us with left shoulder pain, swelling, and limitation of movements. And when we got the X-ray done, this was the X-ray and he sustained a fracture at the metaphyseal region of his left humerus. So what should be the management? As the age is 12 years, sir. And there was a significant displacement, well noted on the X-ray.
Try close reduction under GA first.
Okay, and then putting a cast, sir,
Pinning,
use
pinning.
new cast.
In the fracture.
I would use a pin. I would pin it
Pin.
to assure a reduction later on.
That's
Also.
what you did in the last class.
Okay, yeah. Same thing I did. I did the pinning, and these were the post-operative follow-up images. We did the 2 pinning from the lower side and 1 pin from the above. And this was the final follow-up image after the implant removed.
What is the need for that vertical pin? Top.
Sir, this one?
Yeah, this one.
Not exactly required, sir. Actually, if I would say not exactly required, I just placed it just to be more secure. But if correctly, it's not that much exactly required. Actually, two pins from the below are enough, maximum times.
The one thing is, both the pins are crossing at
Will you read that the pin,
Ravi?
anti-grade pin is put on the top?
One more thing, both the pins are crossing at the fracture side.
Yeah, sir. Actually, both the pins initially I've tried just to keep on the below the physis, but somehow I was not getting that much stability in those pins. Actually, maybe because of the fracture fragments or like that. So that's why these were the smooth pins. That's why I passed the pins through the physis.
No, that is okay, but avoid crossing at the fracture side because biomechanically they are behaving like a single pin.
Yeah.
They should be parallel or slightly divergent.
Yes, sir. Point well taken, sir. Thank you, sir. So this was the final follow-up image. Thank you. Actually, I have included these cases because these were the cases that were left in our presentation.
Very interesting, actually. We always humble in these cases, actually.
So,
Dr. Ravi?
Yes, sir.
Can I make a comment?
Sir, please go ahead, sir. Please.
You know, the pin that Dr. Vikas pointed out that comes from the top, you know, the anti-grade pin. Actually, that is the first pin that we put to hold the fracture together, and then we start putting in the retrograde pins.
Okay.
So that is the easiest to put actually because you have a lot of space and it's much easier on the top.
Yes.
Well done.
Thank you. So I think we are already too much late. We have already crossed the 9:30 mark. We are 1 hour
We have
late.
crossed by 1 hour.
Yeah, it was a great presentation by eminent faculties like Dhiren sir, Sandeep sir, and Vikas sir, and Dr. Prateek. It was great show. And I'm really thankful for everyone. So now I would like to invite Atul sir or Shekhar sir just to conclude the meeting, please.
I think Dhiren sir has left.
Yes, sir. Dhiren sir and Sandeep sir has left.
Sandeep sir.
Yeah.
So you please convey our thanks to him, both of them, and
I will.
the excellent presentation. All 4 presenters were great, and it was a nice interaction also.
Yes.
And it was we also learned so many new things regarding the pediatric orthopedics. So thanks, Prateek, and thanks, Vikas, for sparing your valuable time and to be with us.
So it was our pleasure only.
Sunday late evening and late hours. It's a family time for all us, but definitely we are really grateful to all our presenters who have attended today, and I thank all the delegates also who have joined today for this meeting. Thank you so much, and it was a wonderful evening spent in an academic atmosphere. Thank you so much. Dr. Shekhar?
Thank you, Dr. Atul.
Dr. Shekhar is there?
Shekhar sir must be taking dinner.
Okay, then we close the meet.
Thank you, sir.
Yes, sir.
Thank you, Atul sir.
Thank you, Ravi.
Good night,
And I want to thank the OrthoTV also for being associated with Delhi Orthopaedic Association, and special thanks to Ravi for organizing this CME. Thank you, Ravi.
Thank you, sir. Thank you.
Thank you,
Ravi.
Thanks,
Thank you,
Atul
Dr.
sir.
Ashok. Thank you.
Thank you. Thanks.
Thanks, Atul sir.
Bye,
Thanks.
sir.
Thank
Thank
you,
you,
Lalit sir.
Ashok.
Thank you.
Thanks, dear. Thanks.
Thank you, sir.
Good night, everyone.
Good night.
Good night. Lalit, good night.
Good night, Ji. Thank you. See
Good
you
night.
tomorrow morning.
Well done, Ravi. Beautiful presentations.
Thank you, sir. Thank you, sir.